everyone, and thank you for joining this discussion. Particular thanks to the organisers for such a great event, and to Professor Sir Marmot, who I think provided a really inspiring introduction to the day. It was very thought-provoking. We're presented with this data quite regularly in our areas of work, but it still feels so stark when you see it. So my name is Becky Jeffers. It's a privilege to be here, and I hope I too can contribute to today's discussion. So today's presentation that I will be speaking through is based on research we conducted under the support of the Children's Rights Alliance. And effectively what the research sought to do was to look at this idea of developing a dedicated public health nurse service in Ireland. So we're very familiar with, as we spoke about earlier today, the social determinants of health. There's quite a lot of research internationally about how public health nurse intervention in the early years is really critical in terms of, I suppose, supporting families and children in identifying issues in the early years, but also then connecting these families to communities, services, and related infrastructure around them. So very briefly, I want to speak about this idea of the social imaginaries of childhood. And this is something, whether we think about it or not, is what has brought us here today. So our childhood social imaginary is a shared vision of what a good, healthy childhood ought to look like. This refers to the collective belief that children are not just future adults, but are people who deserve safety, care, and opportunities in their own right. It's the understanding that childhood is a protected period, where children have an opportunity to develop stable relationships, emotional security, that they have time to play, to learn, and to have access to nature, and lots of room to grow. So when society shares this vision, and I do believe we share this vision in Ireland, public health becomes a necessary building block for achieving this outcome. Investments in pre- and postnatal care, early childhood services, nutrition programs, and mental health supports for both children and caregivers are all crucial components in achieving this. Public health is only one of those building blocks, recognising as we do that clean air, secure housing, and the financial means to participate and connect with communities aren't luxuries. They're essential developmental conditions. When we believe all children deserve the same chance to thrive, we confront disparities in poverty and in disparities to access to healthcare and environmental exposures. So for those involved in public healthcare work, there is an understanding that this is not just about treating illnesses, it's not just about preventing outbreaks, it's about fostering social environments and norms that allow children to flourish and to support caregivers during what can be a very challenging time. So, commitments to healthy childhoods. In Ireland, there has been a variety of commitments to supporting healthy childhoods and recognising that this outcome can't be achieved in a vacuum, and this is why we're all here today to advocate for this. It requires a cross-departmental effort of public health, and public health must play a key role in that. The future of healthcare, so this is a Sláinte Care report in 2017, had recommended public health nurses who are dedicated to child health work be put in place, and investing their time in child health and wellbeing services. We also have another key document and programme, which is the National Healthy Childhood Programme, of which many of you will be familiar, in which all infants and children are provided with universal clinical care. So these are the goals of these documents, and most recently, the first 5 is probably a document that you're quite familiar with, also restates these objectives. So this sort of policy context, this policy landscape is really important because it colours for us what a good childhood looks like, what children need to thrive, what responsibilities adults and institutions have towards children, and which conditions society must create to support healthy development. So this is effectively the context in which this research is occurring, or the goal, the context goal. But effectively, as has been mentioned earlier, and I hesitate to sort of reiterate some of the points, many of these goals which are established in these documents and in conversations between advocates and political parties, we also live in a context in which childhood poverty is still a significant issue and indeed an increasing issue. So taken from the Children's Poverty Monitor from 2025, which was analysing the SILC data of 2024, we can see that children's poverty rates and rates of consistent and at-risk poverty are at kind of reaching the financial crash levels once more, which is a very, very concerning trend. So over 250,000 children are experiencing enforced deprivation, and this was in 2024. So that is 1 in every 5 children in Ireland. So they are living without minimum essentials for a decent standard of living, and the Monitor also notes that there's been this significant spike in inconsistent poverty. The diversification of need brought about by this poverty is also a key consideration when thinking about public health, thinking about the social determinants of health and children's outcomes, and should serve as a through point in all the discussions today. As it highlights that there's likely additional stresses on caregivers that they're experiencing in terms of insecure housing, childcare, leisure exclusions, and indeed health-seeking stigmas, which is something that comes up a lot when we think about healthcare. So healthcare exclusion remains a significant issue facing families, and there are a number of different areas that this kind of comes through in the research. And one of these relates to even just the threshold relating to medical cards, which is a really significant issue for a number of people around the nation. And while there are different groups who have access to medical cards without question, there are additional barriers for them to access health. So children of asylum seekers and so on can access without means test, but there are additional challenges and barriers for them to actually access the healthcare that they need. So the context is quite complex when we think about public health and this idea of its universal access. The landscape of support, there's a variety of other documents, but these are the key documents that coloured our research and informed our kind of goals in terms of what we were looking for in international models. So recognising that there's a far-reaching impact of poverty and social exclusion, particularly when we try to imagine equal, flourishing, healthy childhoods, there is this term called the landscape of support, which occurs in a lot of documents, and particularly in the first 5. And this is where, effectively, there is an effort in terms of cross-departmental support in achieving both access to public health care, but also in responding to poverty. So in responding to poverty, in responding to healthy and developmental outcomes for children and young people, there needs to be clear governance across these departments in terms of each department planning and supporting kind of these particular goals. But an important factor here as well relates to the third sector. So the community and voluntary sector in Ireland plays a really key role in terms of offering an additional social safety net for lots of families in need outside of formal public sector kind of roles. So the public health context. The diversification of need, as I've spoken about, warrants kind of greater attention when considering the social and relational nature of childhood development. So poverty, homelessness, migration, and all these other trends present as policy challenges to resourcing and implementing public health nurse services to infants in a universal fashion. It is important to note that responding to these health and developmental concerns of children reflects only one piece of the puzzle, and as a result, there needs to be a significant social policy effort to respond to wider needs so that public health nurses aren't left as sort of bandages on what are wider preventable or respondable social needs. So the role that public health nurses play in Ireland currently is generalist in nature. So public health nurses provide care and advice to all age groups, all circumstances, and this generalist character of the responsibilities is hugely positive. It offers cradle to the grave coverage is a term that we used in our report. But it also means that public health nurses are extremely stretched in the work that they do. There is this plan and proposal for universal care, but we're also witnessing a significant crisis in staffing public health nurses, again, due to heavy workloads, huge responsibilities, and that is a huge, huge challenge. So, as applied to the postpartum period, so part of their training involves this period of the 4th trimester, public health nurses provide universal conduit for new parents. This visit includes maternal and newborn assessment, as well as an opportunity to provide key information in relation to care, health, and social supports within the community. This continuity of care provided by public health nurses is a significant nexus for this wider landscape of support, because it applies local knowledge, it applies familial knowledge to individual circumstances, and that is really critical. So increasingly, these interventions offer not only an opportunity to respond to health concerns, but also a chance to ameliorate challenges brought about by poverty, disadvantage, and vulnerability. By building connections between parents, governmental and non-governmental services within community, PHNs play a really important role in creating connections of care and communities of care. And I'm going to speak about a particular case of Kidscope in the next slide. So all of this involves quite a significant amount of training. Public health nurses, from our perspective and what we reviewed in relation to infant and maternal care, they have a really, really comprehensive training in what they are practicing in the context of these familial settings, from the promotion of breastfeeding to bereavement, to identifying kind of healthy development of well-being of infants and children. But again, the issue is access. The issue is, do we have enough public health nurses to actually commit to the children being born within the country? So, crucially, and I think this was a point that was made much better by Professor Marmot, but also crucially, they have a really important role in targeting misinformation. We're living in a time where there are narratives around public health that are informed by misinformation, and there is a kind of a challenge to the public health nurse kind of process, particularly in relation to vaccinations. So one key part is developing healthcare literacy, but equally challenging misinformation in a supportive way so that we can develop trust in healthcare, which is really, really important for children and families. So the case that I want to speak to you a little bit about, and it kind of based around this idea of community. Community is really critical in terms of our understanding of the role of public health nurses. So building communities of care, building connecting relationships of care. And public health nurses, in a lot of the literature were really identified as cornerstones of children's development in a lot of ways. And one way in which we saw this was through the project Kidscope, which is a specialist pediatric service within the community of Northwest Cork City. And this particular area that Kidscope is based in is an area of kind of profound historical disadvantage. So the catchment area of Kidscope in this context is really, really aimed at targeting a community in need and children who are in need, and indeed families who are in need. So many children in the community experience complex needs already. There is typically kind of poor educational and health outcomes within this community. So the Kidscope community service was developed as an interagency way of establishing these relationships. So Buckley et al., who've been kind of completing very significant and important research on Kidscope, explained that PHNs are the main referring agents to Kidscope. They offer administrative assistance, support for the family, and provide local knowledge and health and development expertise to Kidscope. This aspect of local knowledge reflects a wider practice of PHNs in building trust and relationships with families in their work, and also serves to really respond to help-seeking stigmas which can exist in the area. So they're also key partners in addressing avoidable development delays and contribute to kind of key work in developing the area in general. So PHNs are constantly reported within this particular piece of research as having huge roles in supporting families and committing to future health plans when developmental issues arise or health issues arise, to avoid that cessation period where someone receives a diagnosis for their child and then can't access a specialist healthcare for wait lists or any of these reasons. So they're really important in seeing through that healthcare plan or developmental plan. Another important kind of community-based intervention that we saw was the example of PAVI Mothers. So PAVI Mothers was a critical example of women in the travelling community working alongside public health professionals and traveller health workers in order to support traveller women in coming to understand the kind of public health requirements, what they have rights to, how they can access these supports, and equally how they can access key information that may be less accessible to them in terms of the information leaflets that are being provided within healthcare settings. So this is a really positive example, again, of communities working together with existing infrastructure to provide support to people who want and need it. So we have looked at a couple of models within the context of the research. And the kind of goal was to look at this designated approach within public health nurse principles and practice. So we looked at Norway, Italy, the United States, and the United Kingdom. And there are some really positive reflections that we need to kind of draw attention to, which is there is significant continuity between the outcomes of children in Ireland who go through their developmental and health checks in the same way that occurs within these nations. In that there are many of these models. So there is, there's an increase, for instance, in school readiness, in language development, in necessary intervention and preventative care, but also many of these models also highlighted that there was a decreased chance of injury occurring for these children who went through these programs. The kind of key distinction that we were witnessing across the 4 different nations was the degree to which they were targeted or universal. So Norway, being a Nordic country, has a very significant universal approach to its provision. So much so that one of the programs was actually a requirement in a geographical area, that it was legally required for young parents or new parents to go through this, intervention or developmental check period. But the other program that I think a lot of people are quite familiar with was the case of the United States, so the Nurse Family Partnership Program. The reason that this program was very interesting to us is because of the wealth of data they collected to showcase the significant benefits for children from disadvantaged communities in accessing public health care from early years. both in terms of the support of families and the support for families, but equally, again, this access to are these particular outcomes in relation to language development, feelings of belonging, connection to community, participation within their community, school readiness, and preparation for development and growth. So in the Irish context, we have a couple of kind of points to reflect on in terms of thinking about a dedicated or a designated public health service for children. By all accounts, I think in any of you who know public health nurses or who've been through a process, there is something to be celebrated in the work that is currently done by public health nurses, because it is an extremely challenging, far-reaching role that demands a lot of the people who are involved in the work. If we are to think about the sort of specialisation of children's public health nurses, there needs to be significant and ongoing resourcing regarding training and specialising. But I also think there's a real need to make these roles more attractive to people who are engaging in any of the social and health professions. By and large, these roles, again, we could suspect that some of the public health nurses who are working in Ireland today are also experiencing financial struggles tied to housing precarity, maybe like working in a catchment area that is far from where they live. So that is a really significant consideration. We need to think about children, but also the workers who have their interests at heart. And I think the same applies to any of the social professionals or educational professionals who work with early years. There needs to be an accounting of the range of responsibilities currently fulfilled by public health nurses. And again, I think this idea of actually devising a designated approach could be really positive in terms of how we deploy public health nurses. But again, the extent of their role makes it very difficult for them to reach those who may be most in need of their services. Waitlists for specialist referrals and caregiver support is also a critical issue, in that we see a cessation period from a point where a developmental check has been made, where people end up on a waitlist waiting for specialist intervention, where following through with the care plan, maybe 6 months down the line, is quite a long period, particularly at very important formative points. Participation from family and children in informing practice and training is critical. We have a really encouraging kind of range of people here today, but I also think it's crucial that we engage in consultations with public health nurses, with key stakeholders in that respect, but also with children and families who have gone through this process. I've heard of some really interesting research by people out here in the audience today that I'm really looking forward to tucking into. But again, these conversations need to be inclusive of those who they affect. Reducing stigma, and this is a huge issue in Ireland, it is something that we witness quite significantly with the rise of poverty, is that stigma in help seeking is a really huge issue for people accessing healthcare, accessing social services. So there needs to be considerations around meaningful universal provision, what that means, and how can we support people to advocate for themselves, particularly in cases like healthcare settings, which can be extremely nerve-wracking and sometimes exclusive, and language can be exclusive. So finally, a coordinated response and relationship building within the third sector, and I think that this is what we're witnessing here today. Again, there's a huge range of powerful, interested people who are dedicating time and energy to this conversation. But that conversation needs to occur across these agencies as a means of actually thinking through what can be achieved. I can skip the last slide because I'll just keep going on. Thank you, Denise. Thank you, everyone.